Good evening, everyone, and thank you for joining us for tonight's Woo You event. We are joined by Dr. Jason Jedlicka, and the title of his presentation is Exploring Innovations, Advanced Solutions for Scleral Lens Challenges. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Bausch & Lomb for exhibiting at this event. We'll get to hear from them at the end of the presentation, so please join that presentation at the end. They'll be able to talk about some of the really awesome features that are available in the Zen lens and all the customization features that you might want to know about after this presentation. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. The COPE certificate will be emailed to you within about 4 weeks, so please be sure to fill out that survey link that's in the chat. And we will not have a QR code tonight, but you will get those CE certificates via email soon. We'll save questions towards the end if you want to ask those either in the chat or the Q&A section at the bottom. And then if you're on your phone, you can find the Q&A at the top there or the chat feature under the 3 dots under More. So to introduce our speaker tonight, Dr. Jedlicka is a professor at Indiana University School of Optometry and is the director of the Cornea and Contact Lens Service. He earned his diplomate in the American Academy of Optometry's Cornea, Contact Lens, and Refractive Technology section. He's a past president of the Scleral Lens Education Society, a fellow and board member of the Contact Lens Society of America. He's contributed to multiple textbooks as an author on the topic of GP lenses, was awarded the 2016 SOPR Award for Contact Lens Education, GPLI Practitioner of the Year Award for 2021, Scleral Lens Education Society Scleral Practitioner of the Year for 2023, and the 2024 GPLI Educator of the Year. And as a former contact lens resident, I'll say that the contact lens specialty world is a very small world, and it was very clear when I joined that Dr. Jedlicka is one of the goats of GP and scleral lenses, and one of the smartest and most humble guys that I've met in that world. So really excited to hear from him tonight. Thank you so much for sharing all of your knowledge with us.
Well, you are welcome, Dr. Sorenzi. Appreciate the intro and the lead-in for tonight. My financial disclosures are here. And so we are going to talk about exploring innovation in scleral lens design. And we've come a long way in the last 20-ish years of scleral lens prescribing. I can still remember prescribing lenses back in like 2004 that were completely spherical, and there was nothing else about them other than spherical, everything about it. And it was just like a big gas permeable lens that we just fitted with fluid underneath it. And how things have changed, right? The things that we can do. We've all seen pictures online of some pretty wacky scleral lenses that can just fit some wild eyes in a way like like a tailored suit fits. So it's pretty cool. And this evolution of what we can do with scleral lenses has been fun to be a part of. It's happened so fast. But there's a wide range of again what we can do with a scleral, from the very basics of a spherical scleral lens all the way up to a completely free-form molded lens that we hope would fit an eye very specifically, and everything in between. And so again, what we want to talk about tonight is I'm going to lead in a little bit. I'll just recap minimally over what Drs. Messer and Kuznar talked about at the last session we had a week ago. And then we'll go into some more advanced topics. And again, we could spend hours and hours talking about some of these advanced topics. We don't have that kind of time, but I want to talk again about a few really critical things in our thinking about scleral lenses that can then lead us into talking about some of these new technologies. So we talk about fitting scleral lenses. There are goals both on the patient experience side as well as on the practitioner fitting side. Of course, on the patient experience side, we want our scleral lenses to give our patient good and stable vision for as many hours as possible. And that means, not having them come in and say, I can wear them for 2 or 3 hours and they get all fogged up and I have to take them out and rinse them off and put them in again. We want them to be clear as long as we can. We also want them to then also maintain wettability. And that's something we won't talk about a lot tonight, but there are ways, again, that's a whole nother topic, is how do we maintain scleral lens wettability? But in order for a patient to have good and stable vision, they've got to have no fogging and wettable lenses. We want our patient to be as comfortable for as many hours as possible. Someone asks, how many hours is reasonable? And that's different, right? Because a patient with a regular ocular health, other than maybe just keratoconus, I'd hope those patients could wear their lenses 7 days a week, 14 hours a day or something like that, right? For the patient with severe ocular surface disease who has a whole host of things going on, maybe 8 or 10 hours is the max we can get. It just depends on the individual patient. But again, we should have a goal in mind as we set forward with our patient in the fitting process. How many hours is realistic to expect them to be able to wear their lenses? And then we also want to maintain the ocular health in the presence of the scleral lenses. And that means we don't want the lenses to cause problems. We don't want them to do harm. And so again, transient issues like a little bit of impression ring on the sclera after removing the lens can kind of freak people out, right? But that's a little less critical than seeing things like neovascularization of the cornea, particularly in the zones of the limbal stem cells where they're predominant, so superior and inferiorly. So we obviously want to maintain normal ocular health, or as normal as possible for that individual patient in the presence of their scleral lenses. We want our patient to be happy. That makes us happy. From a fitting perspective, what are our goals? We should strive for relatively even clearance under our scleral lens. Why do we care? Why would we want that? Well, again, if you're fitting without a relatively aligned fit, and so, hopefully we all fit corneal GPs, or we learned about it at one time. We know what an on-K fit is, or a flat fitting relationship, or a steep fitting relationship. When we fit a scleral lens flat, we're going to end up with an area where we have either inadequate clearance somewhere, probably centrally, or if we ensure enough central clearance, we're going to end up with significantly too much clearance in the periphery or mid-periphery. And so either way you go, you're either ending up with a lens fit that's kind of tight, or kind of close to the cornea in some areas, or excessively away from the cornea in others. And that can create issues with potential settling and that lens bearing down or touching the cornea, or we can have excessive clearance, and that means lack of oxygen and maybe a sloppier fit. So we want to try to align as much as we can, and that's not always realistic depending on the patient. We also want lack of movement, because why? Lenses that move stir up debris and fogging. Lenses that move can create awareness. And lenses that move, we can't put on some of these cool higher order aberration corrections that we can do now that can be game changers for some of our patients. So we really got to get our lenses to be as stable as they can be, both in terms of movement with the blink and also rotationally stable. We're also shooting for centration. Why do we care about centration? We don't want prolapse. We don't want limbal issues. We don't want optical issues with a decentered lens. Again, in a perfect world, we want that lens to center as much as possible. And then we're going for full alignment in the scleral zone. Again, why? Because we want to spread out the bearing, the mass of that lens and its touch against the conjunctiva and sclera as much as possible, as evenly as we can. We want that thing to sit with as much surface area as possible, to create better centration and also to distribute the bearing of that as much as possible, so we don't get areas of compression, redness, rings when we take the lens out, things like that. So again, all these things are things that we should be striving for, and we can't always get them all perfect, but we should try the best we can. Again, so these are some examples of when we don't have a good fit. You're going to see on the far left, you'll see our picture of an eye that has some tightness at 3-ish and 9-ish. And so again, that lens is digging in, it's creating redness, it's probably causing discomfort. The patient's not happy about it. People comment, why are your eyes so red, etc. We can see a situation bottom center here at the fluorescein pattern. This lens is dropping inferiorly. What's the problem there? We're touching the superior limbus a little bit. Maybe that's a problem, maybe it's not. Maybe this lens is moving during the course of a day. It could be rubbing against that superior limbus. Maybe that's a problem. Inferiorly, we've got excessive clearance. And so again, we're over vaulting the limbus down there, inviting the presence of prolapse, etc. And so again, we really want a lens to center better than this. Upper right, we can see a situation where we're bearing on a pinguecula. We haven't made accommodation for focal elevations. And then our other two pictures, we can see fogging and prolapse. Again, things that, you know, in a mild way, if the patient's asymptomatic, can we monitor some of these things we can maybe live with, but we only maybe can live with them because we feel like sometimes we can't do better, and we should, if we have the ability to do better, we should do better for our patient's sake. So how do we achieve our fitting goals? We're going to focus on our fitting goals because ultimately, when we have the right fit, our patient's going to meet their own personal goals of what they want out of a lens. If our fit goals are met, the patient's goals will usually be met as well. So I want to talk a little bit about some terminology here. Bottom left picture, you can see a picture of a scleral lens on an eye. And so I'm going to refer to some different things through my talk tonight. Our corneolimbal zone is basically the area, the core diameter of an eye that includes the cornea and a little bit beyond the cornea where the limbus will be, where the limbal stem cells will be, our corneolimbal zone. Again, for most eyes, our corneolimbal zone is going to be a little larger in diameter horizontally and a little bit smaller in diameter vertically. And so again, we need to vault this area, or we need to at least land with the full force of our lens bearing past this zone. Again, I'm of the belief that if my lens were to gently touch some areas of limbus a little bit, but not actually impart any of the weight of the lens on that, that might be okay. But, you know, again, in situations where we just don't want to have the landing of our lens occur on the limbus. So we want to vault the corneolimbal zone, and we want to land on and align as evenly as we can in the scleral zone. Now, and when it comes to talking about our lens itself, I'm going to refer to the vaulting chamber a lot. The vaulting chamber is the part of the lens where we intend it to vault. If you look at a scleral lens, you can see there's this junction between my green and blue arrows where the lens changes in shape a bit. And that junction is where we anticipate the lens is going to first land. So inside that junction, whatever that chord diameter is, inside that chord diameter, the lens may touch the eye. It may brush against it, but it shouldn't put any of its bearing weight on the eye. It shouldn't by design. The bearing weight should all occur in the scleral alignment zone or the haptic, okay? So we're going to talk about the vaulting chamber. We're going to talk about the scleral alignment zone or the haptic as really two different entities. And as we go through a fit, you can almost think about, I've got to fit my vaulting chamber, and then I've got to fit my haptic. And they're kind of two separate entities. And if you tease them apart and think about them separately, I think that's helpful. So, you know, a lot of these issues can be resolved with a scleral topographer. And if you've thought about getting one, you know, I'm not going to say it's going to quote unquote pay for itself with exam fees and whatnot, but it is going to make you much more efficient, both in terms of how long it takes you to fit a scleral lens properly, how long it takes you to get to, you know, even if you use a diagnostic lens, it's going to help you get through the diagnostic process more quickly. It's going to reduce the number of remakes. It's going to instill confidence. The patient will be confident in you as a practitioner because they see you using this. So I think a scleral topographer is extremely helpful if you're going to fit a volume of these. But let's say you don't have one. So I was talking at a conference a month or so ago in the UK, and someone asked me, said, well, I don't have a scleral topographer, so how do I know whether I need something like a toric lens? And I said, well, the key thing here is, if you look at this picture, is if you don't know if you need a toric lens and you put a toric lens on the eye and you let it settle for a few minutes and then you give it a spin, see if it spins back. If it does, you clearly need a toric lens. In this case, you can see how our lens spins right back into place within a couple of blinks. If you spin the lens and it just sits there and it doesn't spin back into place, you probably don't have a toric eye, and you could probably move back to something spherical or with less toricity. So again, this is like a quick diagnostic test in office. Put on a toric lens, let it settle for a couple of minutes, give it a spin with your finger, and see how easily it moves back into the position it was in before you spun it. If it does quickly, you obviously need it. If it doesn't move back, you probably don't. Another thing is, people will say, well, I don't have a scleral topographer. Maybe I don't have an OCT. It's hard for me to see, if I'm getting out past my limbus and where I'm landing, et cetera. Well, guess what? You have you have the lab knows the uh, chord diameter of where that junction is. And again, if you look at the little picture on the lower left, this red zone, this is our landing point where that red zone bends right in the middle. That is where our lens goes from being a vaulting lens to a landing lens, right at that junction. If you know the corneal diameter, and most of us can figure out the corneal diameter one way or another. If you know the corneal diameter and you add a millimeter-ish, let's say, for the limbus, and then you know the size of your corneal limbal zone. You know what it is. And then if you just pick a lens with a diameter where the corneal limbal zone, or where the vaulting chamber aspect of your lens, that chord diameter is at or above what you know the corneal limbal zone to be, then when you put that lens on, you don't have to worry about the lens bearing on the limbus. It's not going to happen, okay? Now, it can happen if it decenters, but when you push that lens back into a centered position, if you've chosen a lens with a vaulting chamber, which is as big or bigger than your corneal limbal zone diameter, you will not have to worry about getting significant limbal issues because the lens is going to land with its bearing points beyond the limbus. Okay, so those are two really big things, to get to happy quicker. If you don't have the access to data, you can use your diagnostic lens to figure these things out. So again, let's start thinking about the ocular surface shape a little bit here. What are the critical points to be aware of? For years, we thought about the shape of the ocular surface, and we would look at the cornea and limbus and sclera, and we'd say, okay, I want to fit a lens on this eye, and I'm just going to make it up. But let's say I want to fit a lens diameter at 16 millimeters. And so maybe I have data that says what my shape of my eye is, and I would look at 16 millimeters as my magic number. And that's okay. There's nothing wrong with that. But the reality is if we really want to fit our scleral lenses properly, I would have you start thinking about the internal landing point, which again is the bend in the red zone here on my picture, which is the end of the vaulting chamber of my lens. It's the beginning of the haptic. It's that junction. It's a magic place in our lens to eye relationship where things change. Everything changes at that junction. And that is the critical part of your fit, way more than it is the edge of your contact lens. And so you've got to start looking at the fit in terms of that part of the fit as opposed to the full periphery, to the full edge of the lens. Okay, so let's say this. Quit looking at just the edge and start looking at the internal landing point with at least as much concentration or attention as you do at the external landing point. So again, we're going to get into some advanced fitting stuff here in just a moment, but I want to again lay this foundation groundwork for you to start thinking about why this stuff will make sense. So let's go back to the idea of corneal GP fitting, because in a lot of ways, again, a lot of the things we do with sclerals, there's a foundation in corneal GP fitting. When you're fitting a patient with a corneal GP and they have a toric cornea, at what point did we always learn that you should move towards a toric? Okay. I always learned it was around 2.5 diopters, maybe 3 diopters, something like that. Okay. So again, the bottom left picture, here's a 3 diopter toric cornea in a spherical lens. B, this is the same eyeball in a toric lens. Okay. And you wouldn't guess that the cornea in B is toric because the lens relationship matches it perfectly. And so if we want to get a beautiful looking fit like we have in B, then we've got to match the shape of the eye as opposed to what we have in A. So 3 diopters of corneal toricity is about 100 microns of elevation difference. And so I will say, to me, 100 microns is kind of a magic number again that I use as a reference. When I've got an eyeball and I'm fitting a scleral lens on it and I've got more than 100 microns of elevation differences, that's the point where I'm looking at adding something to my lens to create a better fit. Below 100, due to the forgiveness of the sclera and conjunctiva, a lot of times we can get by with spherical base curves and haptics. Okay, again, just to drive this point home, here we have a scleral topography to our right. And you'd look at this map and you might look at this and say, well, as I look at the central part of the lens, this cornea looks spherical. And as I look at the scleral zone, it looks toric. And so you'd say, well, so then I should just fit a scleral lens that has a spherical base curve, a spherical vaulting chamber, like we always have done for most of our existence in scleral lenses. And then I should throw a toric scleral zone on that, and that would create a really nice fit. And it might be a decent fit. But the problem again is that the inner landing point of that lens, which is this inner ring that you see of the two rings, this inner gray ring, that's where my vaulting chamber is actually going to land. Not on the cornea, but out there at that inner ring of the rings is where this is going to land. And at that inner ring, I'm already out onto the toric part of the eye significantly. Okay. So again, the shape of the cornea itself is a little bit irrelevant, not completely, but it's irrelevant in terms of how it's going to land. What we've got to do is we've got to look not at the cornea, we've got to look at that area just beyond the limbus where my lens is hopefully going to land if I've picked a proper diameter with a proper vaulting chamber diameter for my cornea, such that I land just out beyond the cornea and just beyond the limbus. At that point where I first land, you're going to find that most eyes have enough toricity at that internal landing point that we should be putting a toric not in the haptic, but we should be putting a toric in our vaulting chamber. And we studied this a few years ago at IU. We did a study looking at a bunch of eyeballs. And what we found again was that for the most part, when you looked at a 12 millimeter cord and a 16 millimeter cord, that 2/3 of the toricity on the ocular surface shape had already occurred at the 12 millimeter point, and that last 2 millimeters on either side had only 1/3. Again, how have we traditionally dealt with toricity on the ocular surface? By putting it in the haptic. Studies will show that we should be putting 2/3 of the toricity that we put in a scleral lens in the internal vaulting chamber, and only 1/3 of it maybe should be going into the haptic instead of putting all of it in the haptic. And again, over the last 3 or 4 years, I think you'll see more and more labs are aware of that, and more labs are putting toricity inside the vaulting chamber of the lens as opposed to putting it just all in the haptic. What happens again when we fit a scleral lens on a toric eye, and we put a toric lens or we put a lens with a toric haptic on a toric eye? What we're going to see is that our lens might look beautifully aligned out at the blue ring, the very edge of our lens. We might say, well, that lens lands on the sclera very nicely at the edge. Okay. But if we look just inside the edge, if we look with fluorescein, which we've got to, again, go back to our roots of looking at everything with fluorescein, what we'd find is that if we'd only put toricity in the haptic, that our fluorescein pattern is going to show excessive fluorescein up here around 12-ish or 6-ish if we had a with the rule eye. So whatever meridian of the eye is the steeper or deeper meridian, we're going to have fluorescein that bleeds out well past the limbus, almost to the edge of our lens before it disappears. If we were to fit that eye with toricity inside the internal part, if we put toricity in the vaulting chamber, we're going to end up with actually a nice, even round circular fluorescein pattern. Why? Because we're landing on the sclera evenly at the internal landing point, not just at the edge. And then we're going to see a nice full ring of alignment between this internal circular ring and the blue outer ring. And we'll show you that in another diagram here. So this is a couple diagrams of what you'd find if you were to look at a toric eye, a toric ocular surface that was typical. Again, 2/3 of the toricity is going to be inside the internal landing point, 1/3 in the outer haptic, the scleral zone. If you had toricity in that eye and you put on a spherical scleral lens, what you're going to see is the picture on the left, and that you're going to see the purple area indicating the area of bearing, and the green area indicating the area of fluorescein. And the fluorescein is going to go all the way to the edge of that lens. So you'd look at that and say, well, gosh, I've got to put toricity in this lens to get the edges to lay down. So if you put toricity just in the haptic, what you're going to see is the middle picture. And the middle picture, what we've found is now we've got an area of touch superiorly and inferiorly, but we still have this oval shaped fluorescein pattern where dye is going pretty far out past the limbus, both superior and inferior in this picture. And that would just, again, depend upon the steep meridian or deeper meridian of the eye. When you actually put on a dual sag lens or a lens that has toricity or added depth to the vaulting chamber and not just to the haptic, we will end up with the picture on the right where we have a spherical or circular fluorescein pattern such that the internal landing point is evenly distributed and we have an even alignment ring all the way around. Again, this is simply by adding the toricity to the part of the lens that matches the shape of the eye within the zone of that part of the lens. In the area that vaults, we want to put the amount of toricity the eye has inside that vaulting point into the vaulting chamber. We want to put the amount of toricity that's in the scleral zone just in the haptic, and that's going to obviously usually be a lot less. If you do look at maps, and we could look at these all day, but again, what you'll see at the top picture shows you the sagittal depth of the cornea at 10 millimeters. So this is just within the corneal surface itself. You see there's not a lot of elevation difference. It'd be rare to find a cornea with more than 100 microns of elevation difference within the cornea itself. But then we move out to 13.25 in this picture. And 13.25, again, is a pretty typical place for a lot of scleral lenses to first touch down. It's a pretty average vaulting chamber diameter. And at that point, a lot of eyes, you can see 150, 200, 250 microns of elevation difference. So what that means, again, is if you put a spherical vaulting chamber, a scleral lens with a spherical vaulting chamber on that eye, you're going to have contact in one meridian just beyond the limbus. In the other meridian, you're going to have 200 microns of excessive limbal clearance or over vaulting. And that creates all the issues we talked about, the fogging, the decentration, the rocking, the prolapse, etc. And when we move out to 16.5, yeah, we see a little bit more elevation difference. But again, we don't want to address the whole 400 microns of elevation difference of that eyeball within just the haptic. We want to put, in this case, we want to put 200 microns inside the vaulting chamber and 200 in the haptic. It's going to give us a much better fit than trying to cram all 400 microns just in the haptic. This is a simulation from a scleral topographer. These are both images of toric eyes that were fitted with spherical vaulting chambers, but toric haptics. Okay, so again, how we would have done it 10 years ago, or how we would have done it even 5 years ago, maybe in most cases. And if you look at these simulated fluorescein patterns, what you notice is in the horizontal meridian, in both cases is our shallow meridian of our eye, that we're pretty close to the limbus in both those cases. We don't have a lot of clearance, and the clearance we have gets pretty tight up against the limbus. As we move into the deeper parts of our eyeball, which would be superior and inferior here, you see the dye going much further out past the limbus in both cases. Again, this is due to the fact that we are hitting the right amount of toricity in our lens at the edge, but we haven't put it in the right place. We should have put a good bit of the toricity in each of these lens simulations inside the vaulting chamber rather than just in the haptic. It would have given us a much better fluorescein pattern. And again, how can you see this? This is a real picture. Typical picture on the left is a patient of mine who is fitted in a spherical chamber with a toric haptic. She has a toric eye. This is, I fitted her like 7 years ago, and I thought this is a decent fit. She's not unhappy. She wears them all day, every day. But even you can see that this lens is decentering inferiorly. You see that we've got excessive clearance inferiorly. We've got inadequate clearance superiorly. When you push the lens into centration, which you must do, okay, you can't look at the picture on the left and do any diagnostic evaluation of this situation in terms of how do I want to manipulate this lens, okay? Everybody, you've got to push your lens into a centered position to evaluate it properly. So if you look at the middle picture, same eye, same lens, centered position. And this goes back and shows us exactly what we saw in the simulations a minute ago, in that we've got very little clearance at the limbal zone in the horizontal meridian where our eye is shallower, but now the dye bleeds out pretty far past the limbus, both superior and inferiorly, giving us that typical oval-shaped fluorescein pattern, indicating that we have a toric eye where we have undercorrected the toricity in the vaulting chamber. Okay, so this is critical to push the lens into a centered position if we're going to do proper evaluation of our fit. These are just some more pictures of a similar situation. This is a toric eye with a spherical chamber and a toric haptic. And what do we see? We see the lens is decentering a little. This one's decentering a little bit laterally as well because the eye is oblique in its axis. But what we see is very little horizontal clearance. We're actually touching on the one side and extending a little past the other. But then we've got this massive overvaulting of the limbus in the other meridian. And if you look superiorly at the picture on the right, you'll see I do have touch. My lens does come down and touch the sclera, the conjunctiva, but that band of touch is like what, 1/3 of a millimeter wide? It's just inadequate. So you might look at that and say, well, my lens is touching. I can't make it any steeper. So if I make it steeper, I'm going to dig into my conj. I'm going to get compression. Okay. Yeah, you don't want to steepen the edge, and yet you've got enough space over your superior limbus that as that patient blinks and moves their eye through the course of the day, you're going to get fogging and debris and tear exchange, and you're going to get the lens is going to decenter because it's not grabbing onto anything superiorly. There's nothing to hold on to up there. And so if we want this lens to stay centered and we want to seal off the fogging and all the other side things, we've got to get that lens to come down and land not 1/3 of a millimeter from the edge. We got to get that thing to land just beyond the limbus. And that means putting a different sagittal depth or toricity inside the internal chamber to get that lens to come down and touch just past the limbus. And then we can actually flatten our haptic because we don't need it as steep if we've already accounted for most of the toricity or the depth difference we need on the internal aspect of the lens. So just to walk through that idea really quick again here, we've got a simulated, or we've got a scleral topography on our left. And if you look at the scleral topography, hopefully you would agree that our meridian around axis 30 and 210 is shallower, and our meridian at 120 and 300 is deeper. Okay, that's what the colors tell us. The red colors, the hotter colors, are closer to us. The blue colors are deeper or farther away from us. And so if we took a spherical scleral lens, and I mean spherical in the chamber and haptic and everything, completely spherical, and we put it on this eyeball, what we're going to see is we're going to see in one meridian, our lens is going to land appropriately. Let me move up and show you that. So if we put on a spherical lens, we're going to land in one meridian ideally, but in the other meridian, we're going to have this massive gap. And you can see that by the picture above. This lens lands horizontally just fine, but we've got this massive channel of space all the way to the edge. Okay. And again, this is typical of a spherical lens that doesn't have any toricity in it whatsoever. So let's say we look at this and we would have said, well, I need to add a toric haptic and that will help. Okay. And a toric haptic will help. What will happen is you're going to see now that in one meridian, we were before, I'm going to have good alignment in our scleral zone. But in the other meridian where I've steepened my haptic and made the edge come down and touch, I've touched at the edge, but again, I have a very narrow area of contact. And that leaves this, in the graphic, you can see this excessive area of limbal clearance in the deeper meridian. Okay. And so again, that gap, the gap over the limbus is what allows for all of these complications that we see to occur. So again, how do we fix that? We move to a dual sag lens or a dual depth lens where we put a toricity inside the chamber. And now this lens lands at the right place, just past the limbus in both meridians. Our haptic is actually not that different shaped. It's not that much different steepening. Like it says, bye-bye prolapse, lens decentration, debris, etc. And you can look up at this eye. This is that same eye we've just been looking at that had the oval-shaped fluorescein pattern that I pushed it up into a center position. When we put a dual sag lens on that eye, look at how perfectly round this fluorescein pattern is now. This is what we want our fit to look like. And you can see again now that in our scleral zone, we've got a lot more surface area between the lens and the eye. And that surface area is what keeps it centered. It keeps the fogging and debris out. It keeps the movement away, etc. So this is one of those things that, again, we talk about innovation with scleral lenses, the concept of going from spherical sclerals. And then again, 10 years ago, it was, oh, everybody needs to be in a toric was all the rage. And all the fitting sets start coming out with 150, 180 microns of toricity in the haptic. And we agreed that's because most eyes are toric. You should be fitting a toric lens of some type on 75, 80% of the eyes you see. The reality now, though, is that we recognize that most of that toricity that we see that we've been putting in the haptic really should be going inside the vaulting chamber. And we really need pretty minimal amount of toricity actually in the scleral zone. Okay. So this is something, again, which is available. I use probably, again, I would say that if I were to look at my fitting profile, I'd say 60 to 70% of my scleral lens fits now are in a bi-elevational or dual sag lens. Probably 15% of them have a spherical chamber with a toric haptic, and 15% are spherical all the way. So again, most of my lenses, probably 70% of them, have toricity, not just in the haptic, but also in the vaulting chamber as well as the haptic. Again, if you say, well, how do I know? The rule for me, again, is 2/3 of the toricity should be in the chamber. So if you put a diagnostic lens on the eye and you know that that diagnostic lens has 180 microns of toricity, and you look at it and say, I think I need even more because it looks good in this meridian, but this one's still flat, and I'm going to order this thing with 240 microns of toricity. Okay, so that's fine. So take 2/3 of that, which is what, 160. So when you order it, instead of ordering 240 microns of toricity in the haptic, order 160 in the chamber and 80 in the haptic. And you're going to end up with a much better fit than if you just ordered 240 in the haptic. Okay. It's an easy 2/3 rule of thumb. Take 2/3 of the toricity that you were going to put in your lens as a whole and put 2/3 of it in the chamber, 1/3 of it in the haptic. That's going to get you a lot closer to your ideal fit than throwing it all in the haptic. Again, consultation at the lab can help you make these decisions. And if you have a situation where you're only putting in like 60, 80, 100 microns of toricity in your lens as a whole, maybe you can just keep it all in the haptic. But again, that 100 microns is a pretty magic point for me, where if I get above 100, I've got to start recognizing I need to put some of this toricity inside the vaulting chamber if I want a good fit. Again, if you've got a scleral topographer, it makes this so easy because you can literally measure the toricity at the edge of the contact and at that internal landing point, and you can subtract the difference. And you can say, all right, in this case, for example, if you look, this patient needs 247 microns of toricity in the vaulting chamber and 562 total, which means I just subtract the two to come up with what I need to put in my haptic. When I call the lab, I can say I need a lens with, I'll just probably say 250 microns of bi-elevation, and then another 310 in the haptic or something like that. Okay. So again, the topographers save you a lot of work. They're wonderful, really helpful. So again, how do you get scleral alignment data without the shape, without the instrumentation? Look for edge lift or compression, which means you need more or less toricity. You know what your diagnostic lens is already. And then from what you know your diagnostic lens is, you can add or subtract as needed to get the right fit. Ask the patient about lens awareness. I think it's really helpful if you ask the patient, where do you feel this lens? Where does it bother you? They're going to be able to tell you areas that are hot spots, either too tight or too loose, to look for. I've looked at a fit before and thought it was a good fit, and asked the patient, where do they feel it? They point me to a spot. I go back and look and go, yeah, I didn't see that the first time, but thank you for pointing that out to me. Lens movement with the blink, like you see in the picture of the video going on, that's a dead ringer for a flat vertical lens fit. Sometimes, again, it's hard to appreciate whether your vertical meridian is too flat, but a movement up and down with the blink like that is a dead ringer for a flat vertical meridian. And again, always please manually center a decentered lens to really look for alignment issues. always please rotate your lens and look for how quickly it goes back to its position. You've got to interact with your lens. You've got to move it around. You've got to spin it around. Again, don't have your patient look up and down, left and right very much. Have them keep always looking straight ahead. But do manipulate, do work with that lens manually to find out where the issues arise. And that diagnostic lens with the dye and your manipulation can act like a scleral topographer for you as you get used to looking at what it tells you. So again, just to wrap up, one of the innovations I really want to hit is this concept of a dual sag or bi-elevation lens. I mean, it takes some getting used to using it, but you should be using this more often than not if you're really doing things right. If you're getting your patients into a good fit, 2/3 of your patients should be in a dual sag or bi-elevation lens. It's just the facts of life when it comes to scleral lenses and the ocular surface shape. And all of these little issues that are not deal breakers, but are annoying little things that our patients will complain about and we're always striving to improve upon, should improve by moving to this route. I want to take the last couple minutes here to talk about some more complex issues. And this is Dr. Messer's patient. You can see this is a very deep, very irregular post-graft eye. When do you need to get into a more complex fits? Again, grafts with a lot of tilt. You're going to see those where the whole cornea is tilted one way or the other. Sometimes post-traumatic eyes can be very irregular, or eyes with what we call a shifting scleral shape. And you'll see as we look at some pictures that the scleral shape wants to move towards an against the rule pattern the larger we get. And so sometimes where the toricity lies in the vaulting chamber or at the corneolimbal zone is at a slightly different axis than it is at the very edge of our lens. So we may sometimes have to do what we call unlocking the axes of our haptic and putting it at a different meridian than the internal vaulting chamber. So we'll mention that here briefly. Just some FYI, this is some data that we looked at in the last year or so, just reviewing a ton of scleral topographies in case you're curious. This is consistent for normal eyes as well, but we looked at 43 keratoconic eyes at a 10 millimeter cord. So this is the cornea. We're talking about just the cornea right now. What you see is on average, the superior cornea is the deepest part of the eye. Okay, why would that be? Well, again, most of these cones are inferiorly bulging, so they're adding depth at the inferior part of the lens. But to get from the top of the cornea to where the cornea lands just past at the edge of the cornea, it's got a deeper traverse superiorly. It's got a farther to go down superiorly because we're bulging out inferiorly. And to get to the 10 millimeter cord inferiorly, we don't have as far down to go as we do superiorly where it's much flatter. So this is a significant elevation difference superiorly versus the other meridians. Now, once we move out to the internal landing point, this is starting to shift. We now see in the right eyes, we saw mostly superiorly still, but it's actually increasingly irregular. We see almost 150 microns of difference between the meridians. And in left eyes, actually, we had flipped to an inferior position with a lot of these eyes. But again, 150 microns of difference between adjacent meridians. Okay, so in this case, between like our nasal meridian and superior or inferior, we see a huge difference of irregularity in that landing point. And as we go out into the periphery, we see, as we expect, our temporal and inferior cornea becomes much deeper, particularly the temporal. And so what's happening again is that when we look at the shape of our eye at our 10 millimeter cord to our 13.25 out to 16.5, the parts of the eye that have the most depth change. And so if we're fitting like a spherical lens, we're going to find that in the cornea, we may have a lot of clearance in one zone, but on the sclera, we've got a lot of clearance in a completely different zone. And so again, what we'll find is that a lot of times we would do better if we could individualize the depth of our lens by quadrant even, not just by meridian, like we just got done talking about, this dual sag, and you're like, wow, this is a lot to throw at me. Something that takes some thinking about. But again, if we could individualize the depth of our lens in each of the quadrants, we would end up with a much more alignment fit. And again, we're talking about, let's be clear, we're talking about lenses that have a spherical optic zone, okay, or a front toric. We're not adding toricity to the optic zone on the back. All the toricity in the vaulting chamber is occurring from the edge of the optic zone to the point of landing on the internal landing point. That's where all the toricity is being built in, so that we don't end up with complicated optics with a bitoric optic zone, blah, blah, blah. Again, as mentioned a moment ago, if you look at the shape of an eye and as you move across the cornea to the limbus, to just past the limbus, to the edge of the lens, a lot of times you're going to find that the meridian of toricity, the axis of the meridian of toricity, is shifting. In this case, on the picture on the left, our corneal toricity is at the blue line, and as we move further and further out onto the eye, it's shifting toward the black line. So we'll talk about the relevance of that in just a moment. Again, we do see this, that about 40% of eyes that we studied showed a greater than 10-degree shift in the axis of the major meridians between the internal landing point and the external landing point. And what that will often cause is you may have what you think is a pretty good fit on your patient's eye, and you're looking around at the fit and you see, gosh, I've got like some edge lift in one area, or I've got a little compression in one area. And as you look at this area of edge lift or compression, you realize this isn't on my flat meridian or my steep meridian. How am I supposed to adjust this thing when I can't steep in one meridian or flat in a meridian because it's between my meridians? Those are situations, again, where you're probably looking at an axis shift of the eye. And if you could simply unlock your haptic and move the steeper part of the haptic toward the area of edge lift, or vice versa, you would end up reducing or even potentially eliminating these areas of peripheral misalignment. Again, as we look at maps, we can see that. We can see, in this case, for example, our deep meridian goes from superior to inferior temporal. We also see that our axis is shifting. In this case, our red line axis is up here around 75 degrees. As we move over, that line is shifting and shifting further. And so this eye has this shift in astigmatism. So if we were really going to optimally fit this eye, we'd want to have a different sagittal depth in each quadrant of our vaulting chamber, and then another separate set of different curves in our haptic that are aligned to a different meridian, axis of meridian of the eye. Again, this sounds very complicated. It can be. Scleral topography helps a lot with it, but your consultation staff at your lab is also capable of helping you interpret this based upon the things that you observe with your diagnostic lens. And so just to wrap up, a 23-year-old female presented for an annual exam. This is just an example of using a complex lens. It doesn't sound like a complex patient, but if you look at the map, you can see that the areas of elevation on this eye are not opposing each other. So we've clearly got some kind of irregularity shaped to the sclera of the eye. We fit this patient in a very complex lens. You can see the different sagittal depths of each quadrant, the different peripheral curves of each quadrant, the different limbal clearances of each quadrant, as well as the axis of each of these, the vaulting chamber versus the haptic. And we end up with, again, a really nice fit, a very nice spherical optic zone or a central fluorescein pattern. The lens is rotationally stable. The black mark is right there at 6 o'clock where we want it to be. The lens looks really nicely centered. So we jump over and look at the left again. We see a lens that is sitting in a good place. The marks are right at 6. Our fluorescein pattern on the right is nice and round. And again, it's very nicely centered. So not saying that everybody needs these complex lenses, but the fun part of this is that it's available now. And this is something you have the ability to prescribe. You can see just, again, some pictures of some lens designs. I do a lot of lens design work, so I'm always looking at these cross-sectional curves. And you can see the picture on the right, far right, shows us the 4 quadrants of a scleral lens with independent values for the sag within the central zone, the limbal clearance zone, as well as the haptic. And you can see that based upon the picture in the middle, that the points of axes of each of these is slightly different as well. So we've created a very similar lens. Again, you can see another example of data-driven lenses with significant differences between the sagittal depths of each of the 4 quadrants all the way through all zones. Again, this is available now. It's pretty cool stuff. And again, if you're like, this is over my head, start with working on the dual sag aspect of things. To fit any of these more complex quadrant specific designs, you've really got to start with a dual sag lens first. And when you've got something that's got a dual sag lens, and then you can start looking at the issues that you still have, sometimes you can move yourself into a quadrant specific sag lens, and that will help resolve even more of those issues. So just in summary, just my own personal tips for y'all. I would carefully look at the ocular surface shape. And if you don't have data, if you don't have an instrument, get your fluorescein strip out and get good at interpreting the patterns down to the minutia of your fit. Recognize when and how to use the advanced design. Use your lab consultants. And the conjunctivitis is forgiving. You don't need to get things perfect, but the closer you get them, the better. Pearls, again, rotate your lenses. See how easy it is to spin them too. When you get a patient coming in and you think you got a tight fit, spin the lens. If the lens spins freely, it's not that tight. If the lens spins with difficulty and the patient cringes as you try to spin it, it's too tight. It shouldn't be hard to spin, and it should spin back to the position it was in before you spun it. Center them when you're trying to adjust the fit and look at the fluorescein pattern. Strive for the maximum amount of surface area in the haptic zone, and that means adding toricity inside the vaulting chamber so that the haptic zone can land evenly 360 degrees away. Off-axis lift or compression requires unlocking the haptic from the vaulting chamber. Again, putting the axis of your sagittal depths of your vaulting chamber at a different meridian than the peripheral curves, steep and flat meridians, and quadrant specific. All that is possible. Again, if it sounds difficult, work your way up to the more complex with the assistance of your lab and get them to help you with it. Having that ability is within your grasp.